Hello, everybody. Welcome. The RSF Early Career Professionals Working Group is pleased to welcome you to this virtual event that we have called Bridging Gaps Between Basic Science Research and Clinical Practice. The goal for this journal club that we are hosting today is to essentially highlight research by a basic science researcher, and then we have invited a clinical expert to also discuss the potential implications on patient management and disease outcomes, hopefully fostering collaboration between these two groups. So for today, we have Dr. Jason Gokey speaking for the first 20 minutes or so, and then Dr. Sujith Cherian speaking for the next 20 minutes, and then we'll have about 20 minutes of discussion and questions from the audience. So to get us started, we have Sergey introduce our first speaker. Sergey?
Sure, I'm happy to. So, our first speaker is Dr. Jason Gokey. He's a research assistant professor of medicine in Division of Allergy, Pulmonary and Critical Care Medicine at Vanderbilt University Medical Center. So he's a highly accomplished professional with an impressive academic and research background. He received his PhD in cellular and development biology from the State University of New York Upstate Medical University in 2015 and completed his postdoctoral training mentored by Dr. Jeff Whitsett and Cincinnati Children's Hospital Medical Center. And his research focused strongly on abnormal epithelial cell signaling related to interstitial pulmonary fibrosis, and he received numerous honors and awards, and became one of the undoubtful leaders of epithelial biology in the lung. So take it from here.
Let's see here. Thank you, Sergey, for that slightly overinflated and very generous introduction. Today, I would like to share with you all some of the work that we've been doing recently, that we recently published in JCI Insight, talking about the role of YAP and TAZ signaling in alveolar repair. This is entirely focusing on the alveolar region of the lung. I've been hiding from the airway for some time. I just saw Bob Forellis pop up on the chat or in the window. So there are plenty of excellent people already doing airway work. But in the alveolar region of the lung, the facultative progenitor is, generally speaking, the alveolar type 2 cell that during acute injury can proliferate and regenerate your alveolar type 2s. And in the case that the type 1 cells are lost, the type 2 cells can differentiate into the type 1s and functionally restore the alveolar epithelial barrier. And then in the context of YAP-TAZ deletion, I will hopefully show you that those abilities of the progenitor type 2 cells are lost in the absence of YAP-TAZ activity. I get to change slides here. What am I doing? Oh, there it goes. All right, so the hippo-YAP-TAZ pathway, functionally the YAP-TAZ pathway is regulated by hippo signaling. Hippo consists of MST1-2 in humans or STK3-4 in the mouse, which phosphorylates SAV1, phosphorylates LAX1-2, and then that phosphorylates, I'm supposed to go over here, YAP-TAZ, which sequestered it into the cytoplasm where it's labeled for degradation and cytoplasmic retention. In the absence of the hippo-on pathway, the YAP-TAZ is not phosphorylated. It migrates to the nucleus where it interacts with its DNA binding partners, TEADs 1 through 4, to activate transcription of genes largely associated with proliferation and differentiation. And then in 2018, we showed that in the idiopathic pulmonary fibrotic lung, which is a progressive fibrotic lung disease, in our normal lung, ABCA3 labels are type 2 cells, and there is very little YAP activity in those type 2 cells normally. And there is readily expressed MST1-2, which again inhibits YAP-TAZ activity. And there's also the absence of the YAP target gene, the JUBA. However, in the IPF lung on the bottom, we see readily detectable nuclear YAP localization, suggesting the pathway is active in these red ABCA3 positive cells. And then we lose MST1-2, the component of the Hippo pathway, likely contributing to the activation of YAP. And then we find the presence of a JUBA, a YAP target gene, in these type 2 cells, suggesting that in the IPF lung, there's activation of the YAP-TAZ pathway. Now, idiopathic pulmonary fibrosis is a form of interstitial lung disease that causes progressive decline of respiratory function, generally caused by, I believe to be caused by a chronic epithelial cell injury that leads to the loss of normal alveolar type 1s and type 2s that results in respiratory decline and is usually fatal within 3 to 5 years of diagnosis. Through that work and some single-cell RNA sequencing, and others have shown that YAP-TAZ is predictive of being a driver of the abnormal epithelial cell differentiation in the IPF type 2 cells. And the IPF lung, we can see here, red is, again, ABCA3, our normal type 2 cells. And then in the healthy donor, we have these alveoli. This is second harmonic generated resonance, so we can see the collagen deposition or collagen in the lung forms these nice alveolar structures. We see plenty of these red ABCA3 positive type 2 cells. However, in IPF, we lose this normal alveolar structure and we have this deposition of collagen. And then in the severe regions, we have even more destruction of the normal alveolar space, which again leads to the respiratory decline associated with the loss of lung function and mortality. So to start off this paper, we first did a time course of YAP-TAZ activation in a single hit injury model using bleomycin, which is our kind of go-to model for fibrotic lung injury in the mice. Now in the mice, bleomycin causes a resolving lung injury. And so we just wanted to determine what the normal activation timeline and status is of YAP and TAZ in type 2 and type 1 cells. So for the type 2 cells, we use surfactant protein C or SBC here in green. HOPX labels our type 1 cells, works reasonably well in the mice. And then in the top in red, we have YAP, and on the bottom, we have TAZ. I seem to have lost my mouse. There it goes. And then throughout the bleomycin-induced lung injury and repair, we have activation of YAP in the alveolar type 2 cells. As you can see here in this little white box, we have red nuclei positive green cells, suggesting activation of YAP. Now, we quantify this over multiple time points, including 4, 7, 14, and 21 days post initial injury. And we found that about 7 days after injury, there's peak activation of YAP, of nuclear YAP activity in the SBC positive cells, where there's about 75% of the type 2 cells have active YAP. And this seems to decline over the rest of the repair process until you get to day 21 when it's almost back to normal. In contrast, the YAP homolog TAZ is not detected in type 2 cells until later in repair, until approximately 14 days, and even then it's only around 30%. But you can see here that TAZ was readily detected in the alveolar type 1 cells, and this has also been shown by a few other groups lately that TAZ is readily expressed in type 1 cells. And this suggests that there's a dynamic activation of YAP and TAZ signaling throughout the repair process. We then wanted to determine Was this activation of YAP really essential to guide the repair process? And so we performed a couple of time courses in which we generated SPC-CRE, ERT2 driven YAP-TAZ deletion, specifically in type 2 cells. We injected tamoxifen 2 weeks prior to the initiation of the bleomycin lung injury. And we were going to look at these mice at 28 days post-injury to see what the effect of knocking out YAP and TAZ was in that repair process. However, deletion of YAP-TAZ in type 2 cells prior to injury caused severe mortality by 14 days post-injury, where we had to actually sack the animals 2 weeks earlier than planned with a 0.08 dose, which is our normal single dose level of bleomycin. We then lowered the dose to functionally half a dose of 0.04 units of bleomycin per mouse lung. And even these mice started to decline rapidly by 14 days, suggesting that if you delete YAP-TAZ prior to injury, you have basically failure of alveolar repair, leading to mortality in these mice. Sorry. And then to try and find a model in which we don't lose the mice and we're able to actually study the role of YAP-TAZ in the epithelium, we delivered tamoxifen at the same time as the bleomycin dose, and then let the mice go out to 28 days. These mice still had increased mortality by 14 days after injury. However, we did still have a little bit over half of the mice remaining by 28 days post-injury. This allowed us to actually analyze the mice and look deeper into the role of YAP-TAZ in type 2 cells during repair. So deletion of YAP-TAZ in the type 2s resulted in increased fibrotic remodeling in the YAP-TAZ delete mice compared to either lineage labeled wild type or YAP-TAZ flox control mice, suggesting that deletion of YAP-TAZ induces lung injury and activation of the fibroblasts, leading to increased collagen deposition and fibrosis. This is quantified here by trichrome staining, as well as Circol total soluble and insoluble collagen analysis, all demonstrating that we end up with an increased collagen deposition following YAP-TAZ deletion in these bleomycin injured mice. We then want to look specifically at the role of YAP and TAZ in the type 2 cells in the alveolar repair process. So as I said before, normally a type 2 cell, when type 1s are lost, can proliferate and differentiate into alveolar type 1 cells, which are the functional cells that conduct gas exchange with the capillaries. And so we used lineage labeled SPC-CRE ERT2 TD tomato mice, where we're able to follow the type 2 cells that get recombined and then assess those for SPC markers for type 2 and HOPX for type 1. I swear I haven't been coughing all day until right now. Quantification of the SPC positive tomato dual positive cells shows that we had anywhere from 75 really to 90% efficiency in recombining our type 2 cells. And then in normal repair here in the HOPX positive, tomato positive quantification, we're able to show that following normal wild type lineage labeled mice injury, approximately 30% of the type 2 cells become type 1 cells, whereas when we have YAP-TAZ deleted type 2s, this number was nearly zero, suggesting again deletion of YAP and TAZ prevents type 2 to type 1 cell differentiation. And this is actually consistent with work recently from Steen's group, as well as another group where they deleted TAZ in type 2 cells and showed that following bleomycin, they failed to differentiate into type 1 cells. Since then, Sergey and I have done a little bit of EM on these mice. And here we have a normal type 1 cell covering the basement membrane. This is after wild type bleomycin, looks reasonably healthy. I figured this is a respiratory structure function group, so I might as well have an obligate EM slide. And then if you delete YAP, TAZ, and the bleomycin injured mice, you end up with macrophages coming in. We have collagen deposition. And our type 1 cells are largely absent. And we have instead these weird type 2 cells that are expanding out over the basement membrane in the alveolar space and just trying to do their best to kind of restore the epithelium. But there was a marked absence of the alveolar type 1 cells in these mice. We then want to look at some of the other roles of YAP-TAZ in these mice. Realized after the fact that we never actually put this in the paper, but we looked at day 7 in bleomycin, injured mice with YAP-TAZ delete or wild type, and normally approximately 4% of the, or four, sorry, per frame, normally 4 SBC positive type 2 cells were proliferating per frame, whereas the answer is closer to 0 in the YAP-TAZ delete. YAP-TAZ deletion affecting proliferation isn't really going to shock anyone, which is probably why we forgot to include it in the paper. And then we also generate organoids from these YAP-TAZ delete AT2 cells, and a normal wild type 2 cell can really generate these. These are using serum-free, feeder-free organoids using Tata's protocol. And we were able to generate a robust organoid culture formation efficiency. These cells proliferate really nicely to the point we end up with about 60-ish organoids per well. In contrast, the YAP-TAZ delete organoids fail to proliferate, and they also generate fewer and smaller organoids, suggesting that, again, these type 2 cells do not proliferate very well. And then to look at this in other contexts, we turn to a model that causes epithelial injury, but it's more of an immune response injury, and doesn't normally cause fibrosis. We injured these YAP-TAZ deleted mice with a 3 mg dose of LPS. And again, this doesn't normally cause a fibrotic response. However, in our YAP-TAZ delete mice, we can see the following LPS. By day 7, we actually have the presence of trichome positive collagen deposition, and this collagen persists out to 28 days post-injury, suggesting that this is the absence of YAP-TAZ is enough to drive activation of the fibroblast and collagen deposition, even in the LPS injury model, which we're able to also demonstrate that even in this less severe of an injury model, the LPS injured mice fail to generate type 1s from their type 2 cells, which is down here in E. That by day 7, there's reduced HOPX positive type 1s, and they do not recover by day 28. And this is consistent with Ryan Lacana's work with Yantian over at Temple, where they did this in a bacterial injury model. They were able to show that deletion of YAP-TAZ also resulted in failed type 2 to type 1 transition. And also consistent with Ryan's work, I was hoping for, some sort of novel insight, but essentially deletion of YAP-TAZ activated the fibroblast by increasing expression of cytokines such as IL-6 to recruit neutrophils and eosinophils. So just to put this kind of in some perspective for the rest of the field surrounding the alveolar epithelium, activation of YAP-TAZ has been shown to drive type 1 cell marker expression, at least, if not entirely AT1 cell differentiation. And that was shown by Sinsun's group, as well as us in 2021. And then deletion of YAP-TAZ blocks AT2 to AT1 cell differentiation. That was shown also by Ian Pankala, as well as Ji-Chao Chen's group, which I forgot to put that paper in here. And the concept of YAP-TAZ deletion worsens alveolar repair and induces activation of fibroblast. Again, Ryan was able to show that in 2019. And then YAP-TAZ alters alveolar repair following bleomycin injury. Steen's group showed that very nicely a few months before we did, that deletion of YAP-TAZ worsens bleomycin-induced lung injury as well. And so with that, overall, we're showing that you end up with structural abnormalities following YAP-TAZ deletion, I didn't show here, but we also have single cell analysis showing that this deletion does in fact activate the fibroblast, which leads to your increased collagen deposition, leading to the functional abnormalities in which your AT2 progenitor cells lose their progenitor capacity to regenerate type 1s or even to really replace their type 2 cell population, which results in an increased immune response, loss of lung function, and loss or increased mortality following lung injury in these mice.
Thank you, Jason. That was a really good presentation. I'd like to next introduce and thank Dr. Sujith Cherian, who is going to be our next speaker. He graciously accepted our invitation to take part in this Journal Club initiative to connect both our basic science researchers with our clinicians to excel the field of research in pulmonology. He comes to us with a medical degree from the Government Medical College in India. He completed his internship and residency training at the SUNY Upstate Medical University in New York and has completed his fellowship at UT Health in Houston, where he stayed on and is now currently an associate professor within the Pulmonary Critical Care and Sleep Division. He is also an accomplished clinical researcher with interest in pleural disease, especially in interventional pulmonology. He is also conducting research in ARDS with a recent publication in JAMA on prone positioning in acute hypoxemic respiratory failure from COVID-19. Besides from being a great physician and scientist, he has also received multiple teaching awards throughout his stellar career, and I look forward to listening to his presentation and his unique thoughts on the clinical application of Dr. Jason Gokey's work.
Hello, everybody. Thank you again for the great introduction. I'm also very happy to be here. And again, thank you for inviting me to this talk. I will start by sharing my screen and taking off from where Jason stopped. And so basically what we're going to talk is, my thoughts and basically give a little bit of a nutshell on the different pathways which are involved and, basically what we see clinically when we have alveolar epithelial injury and fibrosis, etc. So again, taken off from this is the structural abnormalities that we talked about from Dr. Gokey is the loss of alveolar type 1 cells, increased collagen deposition, and then the loss of the alveolar type 2 progenitor function, increased immune response, and loss of lung function. Okay. And so I'm going to just talk a little bit about the basics to give an idea about what the function is for both alveolar type 1 and type 2 cells. And as we said, alveolar type 1, it comprises only 10% of the cells. These are really squamous cells. And occupies 95% of the surface area. And as you would imagine, based on its very thin and flat structure, or its main role in the lung is really to help with gas exchange. When it gets stretched, it stimulates the alveolar type 2 cells to produce the ever important surfactant, which is really the one of the important factors to prevent alveolar collapse or atelectasis with persistent hypoxemia. So really, when going forward, as far as what is taught in lung physiology, mainly is its function from an alveolar type 1 cell standpoint. And the main function for the alveolar type 2, which is really 60% of this alveolar epithelial cells, but only 3 to 5% of the alveolar surface area. The main role is, as we said, is to produce the surfactants. Then the other function, as again Dr. Gokey mentioned, is its role as a progenitor to create more alveolar type 1 cells when there is injury to the lungs. And as far as the host defense, it has a predominant role in immune modulation as well. So this is the alveolar capillary gas exchange, as we can see. And you can see, and this is basically, again, a diagram showing the capillary gas here and the alveolar capillary gas exchange area here. And really this important part here is the role in gas exchange, which helps in oxygenation and ventilation as far as the lung is concerned. Okay. So now let's look at the lung per se. And, the lung is at a very vulnerable point based on the two reasons. One is it is continuously exposed to all of the environmental antigens, which include toxins, allergens, pathogens, bacteria, viruses, fungi, you name it, through the air, and it is also exposed to all of the blood which is pumped from the heart. So basically, it is at a very vulnerable point because it is exposed to different sorts of insults in different ways. And it is important to understand that almost all of the lung diseases start because of some sort of an injury which happens to the lung. And there is either a delayed, incomplete, or a dysfunctional repair, which is responsible for several of the lung diseases that we see or encounter in clinical medicine. And the injury can occur at several levels. I know Dr. Gokey talked about how at the alveolar epithelial standpoint and the cells at that point, but it may be diffuse, widespread. It may be at the level of the vasculature. It may be at the level of the airways. That intensity and the duration of the insults and how it repairs is really what dictates the clinical progress or the outcome or the progression of a disease. Repair, which is defined as restitution to pre-injury level, also occurs at the level of the cells, as we talked about, as Dr. Gokey talked about. But it generally means starts at the cells, and it would involve different parts of the organ as well. So let's looking at the when we talk about the YAP-TAZ pathway and its possible clinical implications, and given its prolonged outcomes overall, I think about mainly two diseases when I consider it from a clinical standpoint, and one which Dr. Gokey has already alluded to is idiopathic pulmonary fibrosis. But again, as one of my research areas is talking about acute respiratory distress syndrome, and I'm going to state how that each disease process is really an injury which occurs at the alveolar epithelial cells. And because of the widespread lung injury and the dysfunctional repair, it manifests as different stages in ARDS. And then what happens in ARDS is it's basically a widespread insult, particularly and the three common reasons being sepsis, aspiration, and pneumonia. It is a widespread process. So what happens is because of the injury and inflammation results in a profound hypoxemia and hypoxemic respiratory failure. While in COPD, it is really years of insult, particularly most commonly seen with cigarette smoke with its toxins, which causes injury at the level of the alveoli as well as at the airways. And then over time results in loss of respiratory function. And in interstitial lung disease, particularly pulmonary fibrosis, what happens is there are intermittent periods of rapid decline on top of a progressive decline in lung function. And all of this has its basis in a dysfunctional repair and more remodeling secondary to an alveolar epithelial or an airway epithelial injury in several of these lung diseases. Okay. So let's look at ARDS, and again, talking at the functional level here. And you can see on the left side here is a healthy lung here. And on the right side is what is being, this is again coming from the New England Journal, how the initial exudative or the inflammatory phase of ARDS progresses. And you can see that this can be multiple inciting agents. And what happens is there is, as we see, an epithelial injury as well as an endothelial injury. And the tightly packed alveolar epithelial cells, which prevent fluid from coming in because of the tight junctions, are all altered or all destroyed, which then results in a capillary leak, chemotaxis, neutrophil recruitments, and then as a result of which there is flooding of the alveoli, and then surfactant dysfunction and release of several of these cytokines, which then perpetuates an inflammatory cycle. And that is what causes the alveolar flooding, and then, as we said, atelectasis or collapse. And then that is clinically seen as hypoxemia. And then several of these patients end up needing to be on some sort of invasive mechanical ventilation or non-invasive mechanical ventilation, or basically some sort of respiratory support. Okay. Now, it is important to recognize that in ARDS per se, around 80% of the reason why ARDS patients die is because of a superimposed infection or a multi-organ failure which develops. But then what happens in around 20% of patients is that there is this progression of ARDS into this fibrotic phase. And, what happens typically is in patients who eventually recover is that the epithelial cells start to recover. The fluid tends to get absorbed. The endothelial cells are repaired or gets back to its original state. And then there is eventually clearance of fluid, and then the alveoli are devoid or removed of all this inflammatory fluid, which then results and which is manifested as improvement of hypoxemia. Now, when we talk about this is again what we refer to as the fibroproliferative phase. If it gets and this typically happens after 7 to 14 days. And then in those patients who don't respond or who don't get into this proliferative phase, they then go into this fibrotic phase. And what that manifests is basically that there is a progressive epithelial damage, and then the endothelial damage is persistent. The basement membranes are denuded, or there is lack of surfactant protein. And then there is eventual mesenchymal transition or mesenchymal extension into the alveolar and to alveoli, resulting in formation of this development of the or a deposition of this extracellular matrix, collagen. And one thing to understand is what happens is the persistent or the recurrent epithelial injuries will then result in this depletion of these stem cells. And then because there is no stem cells or the alveolar type 1 cells are not being formed, there is no formation of this, the epithelialization does not occur. And then what happens is this mesenchymal transition then with then progressive fibrosis and result in hypoxemia. And this accounts for 20% of the patients who die. And this we saw a lot with COVID because of the persistent fibrosis, because of the widespread damage and persistent damage, because of either a vascular and an alveolar epithelial injury which occurred. And in COVID, the alveolar type 2 cells was the primary cell which was affected as well. So now what happens is when we talk about this is the single most or the most important study as far as this in ARDS, which has happened, is the implementation of low tidal volume ventilation. And basically what they realized and what they understood is the ventilator itself was associated with lung injury, and that minimizing the ventilator lung injury by minimizing the tidal volumes changed the mortality overall from close to 40% down to 31%. So a 9% difference was just seen by changing by making or adopting a lung protective ventilation. And what that basically clinically translates to is it was decrease in the repetitive epithelial injury which happened. And because of that, then resulting decrease fibrosis, decreased persistent hypoxemia, and decreased overall injury to the lung. So the repeated epithelial injuries are important then in perpetuating this fibrosis, because what happens is there is depletion of the stem cells and activation of the aberrant repair cells. So really this fibrotic phase is really one as I think about is one area that this particular pathway could have a clinical implications in. And if we could prevent that progression by modulating this, it would be something that would be of great clinical significance and importance. Okay. So as we said, again, the non-modifiable risk factors, which include age, alcoholism, diabetes, etc., and the modifiable risk factors, including the fluid balance, mechanical ventilation, is really what drives this ongoing inflammation. And the more and more injuries that you add may result in what is the lack of resorption or a persistent fibrotic phase in ARDS, as you can see here. So recurrent infections which happen, again, as we said, the more lung, with the no implementation of a lung protective ventilation can all result in increased mortality, all because of the fact that it may result in worsening pathological fibroproliferation. And this is the different groups which have been done in order to basically aiming at this fibrosis or the eventual part of fibrosis here. The other disease, and again going across along the same lines is again using statins, which are the HMG-CoA reductase inhibitors, and which have inhibitory effects on the APTAS pathway, was studied in 2 trials in ARDS, and one is the HARP-2 study, and the other one is a SAIL study. The SAIL study was done by the ARDS network here, while the HARP-2 was done in Ireland and basically Ireland and Ireland. And a latent class analysis found that elevated inflammatory markers, which included interleukin-6, 8, the TNF receptor, decreased bicarbonate use of vasopressors, was able to identify a hyperinflammatory subtype. And when they applied that class analysis to those patients within these 2 studies, which was the HARP and the SAIL study, which did use statins, which had inhibitory effects on this particular pathway. They found that the patients who had the hyperinflammatory subtype with the use of statins did have overall improvement in outcomes with decreased ventilator-free days, improved 28-day mortality and non-organ failure. But overall, taking both studies with statins, with the HARP-2 study and the SAIL study, there was no difference in outcomes. In fact, the study was actually prematurely terminated because of a lack of improvement in outcomes. But when they applied this latent class analysis to the HARP-2 study, they found that statins in this particular group of the hyperinflammatory type of ARDS did actually result in improved outcomes. So that is one clinical implication that may be there, and it may be that this may be helpful in those group of patients where they may progress into this hyperinflammatory subtype of ARDS, wherein they then result in progressive fibrosis. Okay. Now, if you look at corticosteroids, which is really aiming at decreasing the upfront inflammation, either prior to the onset of ARDS or in the latter half, where they go into the more fibroproliferative phase, did not actually result in any improvement. So the effects here are a little varied, and this is again back when the studies was done in 2006, wherein lung protective ventilation was not instituted as well as it is right now. Okay. So then let's look at idiopathic pulmonary fibrosis, and this is something Dr. Gokey has already alluded to. And again, as we said, the injury is of multiple levels: cigarette smoking, viral infections, pollutants. But it is best conceptualized as a predominantly fibrotic disease that results from recurrent alveolar epithelial injury, then leading to an abnormal fibrotic response. And then what happens is, over time, there is pulmonary vascular remodeling, pulmonary hypertension, which develops. And then they have noticed across all the, looking at explants and basic signs and explants when you do lung transplants for these patients with lung fibrosis, they have been able to find that the normal response with AT2 cells or the alveolar type 2 cells differentiating into type 1 cells does not seem to occur in a lot of patients due to various reasons. So then the basement membrane gaps which develop then permit the migration similar to what we saw in the fibrotic phase of ARDS, wherein there is a migration of the mesenchymal cells causing collagen deposition. And in comparison to some other interstitial lung diseases, how idiopathic pulmonary fibrosis going at a pathology level seems to be different is the dysfunction or the destruction of the basement membranes, which is where in several of these inflammatory diseases, particularly organizing pneumonia, the basement membrane seems to be intact, while in idiopathic pulmonary fibrosis, there is this basement membrane gaps, which then result in a mismatch between a fibrotic and an antifibrotic pool of cytokines, and then promote more fibrosis within IPF per se. Okay, so this is again talking about idiopathic pulmonary fibrosis where there is increased cell death. And then if there is differentiation, well and good. If there is not, then what happens is there is a lack of differentiation, wherein the APTAS, as we mentioned already about, could have several implications. And when there is no differentiation which happens, then there is increased promotion of fibrosis, which over time can result in persistent hypoxemia, mortality, and it is to date the most common interstitial lung disease seen in clinical medicine. Okay. So as we said, the GAP-TAZ pathway, again, in terms of idiopathic pulmonary fibrosis, results in dysfunctional epithelial cells, and it actually may promote fibrosis. And so basically, if you look at different studies targeting treatment in IPF, right? The studies so far done in IPF have all been, several studies have been performed. And really coming down to what has been done as far as steroids, as far as acetylcysteine, as far as the Panther trial, as far as anti-inflammatory agents, they've not shown to have any role. In fact, have not shown any improvement in outcomes, and even in fact worsening outcomes, mainly because of the fact that this is probably a disease which occurs over time, and a particular anti-inflammatory agent has not been shown to have of much benefit. In fact, worse outcomes have been reported in patients with IPF and short telomeres. And because of the overall, overwhelmingly poor outcomes with several of these agents applied in idiopathic pulmonary fibrosis, then the focus in the studies have been towards the anti-fibrotic agents. And these are the nintedanib and pirfenidone, which all have been associated with decrease in disease progression, because it is because they are either targeting the tyrosine kinase, or they are basically acting as anti-fibrotics, which helps delay the progression of the pulmonary fibrosis. Okay. So as we said, the possible pathways as I look at is, if there is an agent, basically the YAP-TAZ pathway may have a very important role in the persistent fibrotic phase in ARDS as well as IPF. If we could, in terms of ARDS, if we could use biomarkers to identify or which aligns with the YAP-TAZ pathway to identify the hyperinflammatory type, then perhaps agents which may target those would be helpful. And that's where the statins seem to have had a role. And then in addition to antifibrotics, perhaps agents to modulate the YAP-TAZ pathway could help in overall improving the outcomes in several of these patients. And as we said, this is really multiple injuries in addition to genetic predisposition, which governs the development of pulmonary fibrosis down the road. Okay. And this is again different agents. I think vortiporin porphin is a medication which has been done, but it has not, it's not clinically useful or cannot be used in humans as yet. But I think the development of some agents which may help or may target that could be something that we could target down the road. But one thing I want to make sure, or one thing that we have to keep in mind is most of the trials which have looked at agents which target one single pathway have not shown to be clinically useful. And really, so a strategy should be that an agent should block multiple channels or more than one pathway. And those are the agents which seem to be more effective in these diseases, particularly in idiopathic pulmonary fibrosis. So as we said, repetitive injury, repetitive alveolar epithelial injury, repetitive airway epithelial injury, and dysfunctional repair form the foundation and pathogenesis of several diseases. And susceptibility to lung injury is determined by previous exposures, stem progenitor cell and their depletion, and genetic constitution. Thank you very much. Open to questions between me and Dr. Gokey. Thank you again.
Thank you, Dr. Gokey and Dr. Cherian, for the fantastic presentation. We'd like to open up the floor to anyone who has questions, but while the questions are coming in, I was just wondering, between the both of you guys, since Jason's article had mentioned that there are changes in the YAP-TAZ activation peak at around day 7 and day 14 post-injury. How does that correlate with our clinical diagnosis of something that is more acute, like in ARDS, where hopefully patients get better with time, and if they don't, then they end up being more fibrotic and chronic diseases, versus something that's just inherently chronic, like the idiopathic pulmonary fibrosis? How does that activation peak at a later point in time change or possibly change a clinical course?
I think it's hard to say in terms of idiopathic pulmonary fibrosis, because by the time the patient presents to us, they're already very hypoxemic. So it's probably after the day 14. And as I said, it's generally what has been seen in a lot of patients is the acid reflux. And most patients have this for many years and these kind of inciting agents for over many years. And then by the time they really clinically present to us is when they're really short of breath, and at that time they've already gone into pulmonary fibrosis and all. Now this is in talking in terms of idiopathic pulmonary fibrosis alone. Now, for example, if it is a patient who may have a interstitial lung disease secondary to a connective tissue disease, which actually forms a big spectrum of diseases that we come across as well, that perhaps we may be able to identify, if it is by day 7 versus fibrosis, before them progressing into fibrosis, if we can catch at that point, perhaps we could prevent them from going into that. And what we do as now in those patients is really treating the underlying disease. But then there is still this group of patients who may progress to develop pulmonary fibrosis. In ARDS, I think, and that's where I think it really has a good clinical relevance. I think if it is by day 7 versus day 14, is typically by day 14, we clinically will know if the patient is not, if by they typically do respond or seem to show some signs of clinical improvement. And if they don't, then we have a strong suspicion that they are going into the fibrotic phase. So the pathway stimulation, if it is by day 7, I think if it makes a difference at day 7, and that is probably where we could maybe let's say our moment where we could act is to prevent them from going into fibrosis. I think that really would have some clinical implication in that one. So I think in ARDS is probably there where we would be able to catch it if at all.
Yeah, I would agree with that entirely. This whole thing with this pathway is all about the timing of it, it seems. The fact that IPF is, we believe, caused by more of the repetitive injury, that with the precise timing of how you intervene would be a challenge. But it did match up quite nicely, I suppose, with the ARDS. As a cell biologist, I've just been thinking about day 7. We know they're still proliferating. By day 14, they're starting to differentiate in the type 1s. And we think that TAZ is heavily involved in the type 1. Because one of the other things that we know from both our work that we are currently in the efforts of getting out and that Steen paper is that sustained activation of YAP is also problematic in the IPF lung and in the mouse lung as well. If we injure the mice and we keep YAP active, we force activate it for too long, because if you remember, it went up and then back down. If you prevent that downregulation, it also causes worsened lung injury.
Let me ask you one question as well. So it's sort of a following up to some extent what you already mentioned, but Jason taught us that the YAP activation is very relevant to differentiation to the type 1. And we sort of, to some extent, assume that it's involved affect the proliferation rate as well, but is it really? And speaking about the combination of the treatment, right? When you need to impact 2 different pathways, right? If the one is about proliferation and not about the differentiation, and timing is important. Not only that it's combinatory treatment, but you cannot like give the same thing at the same time. But can you sort of elaborate on terms of timing wise? Is it one pathway regulate both of this process, or if it's different one? If it's different one, which one you think more important and need to be affected to sort of treat the condition?
So I think it so I think really in terms of in fibrosis, like let's say for interstitial lung disease and fibrosis is where it should be the second, where it's to where it may have more of a role, as because you want to that persistent fibrosis, or basically none of the patients the lung function decline is really in patients with lung fibrosis is more of a steep curve, while as we said, many of these anti-fibrotic agents are basically slowing the decline. So it is a continuous process, and again, as Dr. Gokey mentioned, I think it is a repetitive injury. So I think if we have agents which could block that pathway or that persistent, if you can mainly, like say, if this YAP test is promoting fibrosis towards that one, that is a part I would think we should try to block more in cases in patients who have pulmonary fibrosis, my opinion. In ARDS, I think really it should be the first part, as far as we want to have something which could help stimulate more and more alveolar type 1 cell formation to facilitate the repair now if you look at like, for example, now very recently last year there was a study which looked in, and this was not really in ARDS, but this was in patients with severe bacterial pneumonia, where they used corticosteroids, which is called the Cape Cod study, published in the New England last year. And that implementation of corticosteroids in patients with bacterial pneumonia within 1 day, and the study looked at really 15 hours of implementation, that was able to decrease the need for mechanical ventilation by in the range of 10 to 12%, had mortality difference, as well as the need, as well as them going into organ failures as well. And this was all in the range of 10 to 12% difference just by using steroids. And I think it is all happens because of the downstream effects of cell injury and then the inflammatory cycle, which is perpetuated. So the faster you can facilitate a repair and prevent further downstream injury, I think then that pathway would be I think a target to use in such a case. For example, in any severe pneumonia, for example, in a patient with aspiration who may progress to ARDS, and as I said, in the early exudative phase of ARDS, I would say that we should try to aim for the first role. I mean, that part where it's more of a helping progenitor as an alveolar type 1 cell.
Yeah, I mean, with the pulmonary fibrosis angle, I mean, the overall goal is if we can convince the lung to repair normally all the time, we probably wouldn't have to worry about this. So I think treating it once as fibrotic with this pathway at least would probably be challenging.
So if it's progressive and repetitive injury, right, so it sort of goes in the waves of proliferation, differentiation. So that's maybe why you have this cycle, right, when you have active and it's go decline, so when you have another injury, this goes activation again, and basically you have this like constant waves, and you somehow need to hit the right like part of that wave in the right timing. So the timing of that's very hard to achieve to some extent, and most probably because it's a diffuse process, right? In some place it might be in the day 7 after the injury. In another part of the lung, it might be day 14 of the injury. So it's overall very complicated pathway to try to affect it. But if it's possible, it would be fascinating for sure. And in terms of actual and clinical implementation, that might be, I sort of agree there, ARDS, it's more, you have a more room for treatment here because you know when it's happening in timely manner, and in the clinical side you sort of following this timely because it's like very difficult condition for treatment, and you know this timing, right? If it's happened 7 days ago or 14 days ago, you definitely know that, right? So and maybe starting with that will eventually lead to something that you can use in a chronic injuries as well.
And I mean, the other thing I just wanted to add is it has been well documented that patients who have idiopathic pulmonary fibrosis have these what is called acute exacerbations of lung disease, and that results in the trajectory going down even steeper in terms of lung decline. And that generally speaking, those the histological correlate in those kind of patients when they go to this acute exacerbation is a diffuse alveolar damage at that time. So as we said, it is repeated cycles, but at that time there is probably more of a profound inflammatory effect. And at that time, we really don't have any good agents. So we do, clinically speaking, generally we do antibiotics, we do diuretics, we do steroids in those patients because we have to try to prevent inflammation at different levels.
Okay, we have a couple minutes left. I wanted to take some time to thank our two speakers for wonderful presentations, and we hope to see you at our next virtual event. Thank you so much, guys.
Thank you so much for the invitation.
Sujith, did they say that you went to upstate as well?
Yes, I was going to say that. Yes.
Oh.
I did a residency there.
Oh.
Yeah.
Yeah. Interesting.
Yeah, I was there through 2012. 08 through 2012.
I was there until 15.
Yes.
All right. See you all again soon.
Yeah.
Thank you so much. Thanks, Samantha.
Thank you.
Thank you.